phone and computer microphones during today's webinar. We'd also like to remind you to use the chat box function to type in all questions. And finally, questions will be answered at the end of the webinar. Thank you for your participation in today's webinar, Cost Effectiveness in the ACHN Program. Today's session will cover the details of Medicaid's cost effectiveness evaluation methodology. Specifically, we will cover the following: the attribution process, an overview of the cost effectiveness measurement process, which will include our guiding principles, as well as a detailed look into our risk scoring methodology. We'll end with the description of our bonus determination process, including an illustrative example. We will then open the webinar for a question and answer period. First, let's go through a refresh of our attribution process. What is attribution? Attribution is the process that will be used to associate a Medicaid recipient to the PCP group that provides primary care to that recipient. PCP groups must sign 2 agreements, one with Medicaid, one with an ACHN entity to participate. Under the ACHN program, recipients will be attributed at the group level based on historic claims data. Therefore, PCPs are encouraged to continue seeing patients as medically necessary on a consistent basis to increase the likelihood of attribution. Attribution is a critical factor in determining the distribution of bonus payments among eligible providers. This is particularly true in year 1 of the program. Attribution will replace panel assignments. Under ACHN, the Patient First program will cease to exist, and capitation payments will no longer be paid. We would note that a smaller number of attributed members compared to members in the previous panel does not necessarily equate to a reduced payment. Key steps in attribution. First, only Medicaid recipients that have met criteria for the ACHN program for 3 out of the previous 24 months will be attributed. This does not have to be a consecutive period of 3 months. A previous 2-year history will consider face-to-face provider visits. Both preventative visits and regular office visits will be scored, with preventative visits receiving a higher point value and recent visits being scored higher than older visits. PCP visits receive a higher point value than specialist visits. And finally, a previous 12-month history of filled prescriptions for maintenance medications will be scored. How will attribution work? On a quarterly basis, the Medicaid Agency will determine attribution for each Medicaid recipient under the ACHN program in accordance with the following process. Point values for face-to-face visits will be assigned to the individual provider that is performing the service. Then the individual PCP scores will be combined to form the PCP group's total point score for each recipient. The PCP group with the highest number of points will have the Medicaid recipient attributed to that PCP group. We would note that if a specialist group has the highest number of points, then the specialist group will be attributed to the Medicaid recipient. However, a specialist group will not be eligible to receive bonus payments. Now we'll cover our cost effectiveness evaluation methodology, starting with our guiding principles. First is consistency with ACHN's principles of payment for activity with a focus on health outcomes. Secondly, acknowledgement that risk levels vary across practices. In other words, we are accounting for sicker recipients and therefore more expensive recipients. Adherence to commonly accepted, validated, risk-adjusted methodologies are being used. And evaluation and activities are made at the group level, as are the determination of bonuses, as with our other bonus payments. Let's begin with an overview of cost effectiveness. First, all participating PCP groups will be eligible for performance payment if the group meets or exceeds the cost effectiveness that we will cover today. Medicaid will utilize Milliman Advanced Risk Adjusters, otherwise known as MARA, to assess the cost risks of the ACHN population and apply a customized algorithm to calculate a cost effectiveness score for each participating PCP group. To qualify for the cost effectiveness bonus, PCP groups must have a score less than or equal to the statewide median cost effectiveness score. We will cover this in detail later. Cost effectiveness scores will incorporate the following: the overall risk of a PCP group's attributed recipients, the overall per member per month, or PMPM, cost of a PCP group's attributed recipients, and the overall PMPM cost of the statewide attributed ACHN population. Actual PMPM cost will be compared to risk-adjusted expected PMPM cost for each qualifying participating PCP group, and a final cost effectiveness score will then be determined. Next, we'll cover our MARA risk scoring methodology. Risk scores are standardized metrics that are typically used to evaluate a member's previous health experience and/or to predict health outcomes. Medicaid uses software developed by MARA for a variety of many agency calculations. Several statistical models are employed for all of these processes. Some of our ACHN processes will incorporate what we'll refer to today as concurrent risk scoring. Concurrent risk scores will be used in our cost effectiveness bonus calculations. I would like to remind some of the network entities that might be listening in today's webinar that for other risk scoring models in ACHN, different types of methodologies will be utilized. Again, for cost effectiveness, we'll focus on concurrent risk scores. These risk scores assess member health risks based on a previous year's or a previous period's claims information. This includes cost and diagnosis codes. It then predicts member cost for that same period. In other words, what the expected cost would have been. Concurrent risk scores are based on the claims information adjusted for the risk of the actual experience of the attributed members over the measurement period. In other words, we look at actual claims history to determine the risk. Claims information includes a variety of costs, which include inpatient, outpatient, ER, physician, pharmacy, and other cost categories. Demographic information at the recipient level will also be taken into consideration. Finally, the average concurrent risk scores are calculated as follows. For any given PCP group, we take the sum of the concurrent risk scores and divide it by the sum of the total number of members attributed to that PCP group. In our final section, we'll focus on the determination and distribution of bonus payments for cost effectiveness. This section will include a step-by-step illustrative scenario that involves a hypothetical PCP group. As a reminder, our new payment structure is effective October 1. This includes enhanced fee-for-service rates for selected procedure codes. Bonuses will also be awarded to qualifying groups on a quarterly basis. These are based on quality measure performance, patient-centered medical home activities, and today's focus, cost effectiveness. Also, as mentioned earlier, bonuses are only impacted by attribution in year one. Again, beginning October 1, an annual bonus pool of $15 million distributed over 4 quarters will be allocated among quality metrics, PCMH recognition, and cost effectiveness. 50% will be allocated for quality measure performance, and 45% for cost effectiveness, today's topic. As a reminder, the first quarterly payment will be made on the first check ride in November of 2019. Subsequent payments will be made on a quarterly basis beginning in January 2020. As seen in our schedule below, all bonus payments in year one are based on attribution. But the first calculated cost effectiveness bonus will be made in January of 2021. We'll go into more detail on the next page about this particular payment. What we would note, though, is during this time, the agency will issue quarterly scorecards that will ideally assist practices in monitoring their progress towards these benchmarks. As illustrated in the previous calendar, for the first 5 quarters, that is year one of the program plus the first quarter of year two, ACHN participating groups will receive a cost effectiveness bonus based entirely on the number of Medicaid recipients that are attributed to the PCP group for that quarterly period. Again, we would remind PCPs to continue to see their patients to increase likelihood of attribution. After this initial period, PCP groups will then be eligible for and receive a bonus payment if the PCP group meets or exceeds the cost effectiveness criteria we've referenced earlier. The cost effectiveness bonus calculation that will begin on January 21 will be based on actual cost effectiveness calculated for a period between October 1, 2019 and September 30th, 2020. This allows for a full 3 months of claims payment runout. Subsequent payments beginning in April 2021 will be based on actual cost effectiveness calculated for the period between January 1, 2020 and December 31st, 2020, again allowing for 3 months of runout. This process will continue for each quarter on a rolling 12-month basis. Now we'll cover the cost effectiveness bonus determination process steps. For each group, we will compare a 12-month PMPM to a risk-adjusted expected PMPM. Groups are then ranked by a cost effectiveness score that is derived from actual PMPMs versus their expected PMPM. A bonus payment is then paid for PCP groups who will be at or below the median cost effectiveness score, and cost effectiveness calculations will also include a PMPM calculation for the statewide attributed ACHN population. We would note that our cost effectiveness calculation does exclude certain costs such as network entity case management fees, other bonus payments, certain waiver costs, drug rebates, among other cost categories. The intent here is excluding costs for which a group might not have any control. Now, for our illustrative scenario, we'll consider Gallagher Family Practice, a participating PCP group. For this example, we're going to walk through 3 primary process steps. Number 1, member attribution. Number 2, cost effectiveness scoring. And number 3, bonus payment determination. These steps will all be illustrated below in our flow chart, and after each process step, we'll go to a more detailed illustration that compares Gallagher Family Practice to 9 other hypothetical statewide practices. Before we get to our first process step, step 1, which is member attribution, I'd like to remind you of 2 primary assumptions in this example. First, we are assuming a total number of statewide ACHN members attributed of $500,000. We are also assuming a quarterly cost-effective bonus payment pool, in this case, of $1.687 million. So for our first process step, we'll start with Gallagher Family Practice. In this case, the members that are going to be attributed to Gallagher Family Practice is 6,300 in Step A. Going left or right to Step B, we calculate the distribution rate of attributed members. This is simply taking the members attributed to Gallagher Family Practice and dividing it by the total number of ACHN statewide attributed members, 500,000. This gets us to 1.26%. This next table, staying with process step number 1, for illustrative purposes, compares Gallagher to 9 other statewide practices. Here, you're able to see how the member attribution is awarded to the 9 other practices and how the distribution of members, attributed members in each practice adds up to 100%. We'll come back to this chart for every step along the way. Step 2 of our process really focuses on the cost-effectiveness scoring methodology. Here we'll start with Step C, which is the determination of the PMPM for our practice, Gallagher Family Practice. Here we calculate a PMPM of $462. Below, in Step D, we also calculate a statewide PMPM. Again, this is the statewide attributed ACHN members. In going to the top right-hand box, Step E, we then calculate the risk score for Gallagher Family Practice. In this case, it is 1.89. For reference, a practice risk score of 1.0 would be average risk and therefore average cost. So what this means for Gallagher Family Practice for this quarter is their list of attributed members have higher risk and therefore potentially higher expected cost. Going down the chart, going to Step F, we then calculate Gallagher Family Practice's expected PMPM. This is done by taking the group risk score. Again, this is the 1.89 risk score. We then apply that risk score to a statewide PMPM. Again, in this case, that would be $297. What this gives us is an expected PMPM for Gallagher Family Practice of 561. In other words, assuming their risk level for their attributed recipients, we would have expected a score, a PMPM of $561 for that quarter. Moving right to left, going to Step G, we then calculate their cost-effectiveness score. And this is done by comparing their actual PMPM. Again, that is Step C above. Their actual PMPM is $462. We then divide that by the expected PMPM, again, Step F on the chart. This gives us a risk score, a cost-effectiveness score rather, of 0.82 that we apply to the practice. Generally, this means this is an efficient score. The next key step in our process is scoring every qualifying participating group in the state. And in Step H, this shows how we determine our median cost-effectiveness score. By attributing a score to every group in the state, we are able to rank them. And by ranking every group, we choose the median, or think of it as the middle score. And in our hypothetical example, the statewide median, and therefore our cost-effectiveness score, is going to be 0.86, which leads us to a key step in the process of who qualifies for cost-effective effectiveness bonus. If groups score below the statewide median, in this case 0.86% or 0.86, if they score above this median, I should say, they will not for the cost effectiveness bonus. However, if they do, and in this case, Gallagher Family Practice has a score of 0.82, which is at or below the median. This is seen in Step I. This means they are eligible for the cost effectiveness bonus. So this leads us to the last step in the cost effectiveness scoring process. The next step is seen in the bottom left-hand corner, which is steps J and K. What this step does is eliminate attributed members in groups that scored above the cost effectiveness score. In other words, we're eliminating members in groups that do not qualify for the bonus. So what we do is recalculate the distribution rate of attributed members by taking a group's number of attributed members for the quarter. In this case, Gallagher has 6,300 attributed members. We then calculate that by the attributed members in groups at or below the median threshold. That is our qualifying groups. In this example, that number is 307,000, and this gives us a new distribution rate of 2.05% for Gallagher Family Practice. Now, we'll go to the more detailed table that shows how Gallagher Family Practice compares to the 9 other statewide groups. We'll first start with column G, which is the cost effectiveness score for each group. Similar to Gallagher Family Practice, we see how the scores were determined for each practice. And in this case, this illustrates how the median score of 0.86 was calculated by looking at all the scores in the state. You're also able to determine in this chart whether or not any given group was at or below the median and therefore would qualify for the bonus. Going to column J, we then recalculate our member attribution for these groups that have met the threshold. So this recalculation shows you how we now have the 307,000 attributed members for qualifying groups. And finally, step 3, our final step in this process, shows how bonus payments are determined. Again, we'll start with step L. Again, this takes the same bonus distribution rate that we just saw in the case of Gallagher Family Practice, that is 2.05%. We then apply that rate to the quarterly pool amount, again in this case $1.687.5 million. This gives Gallagher Family Practice a quarterly bonus payment of $34,591. And again, comparing Gallagher Family Practice to the other groups in the state that qualified, you can see how the math works for their new distribution rates applied to the quarterly bonus. And this is a key step in our process, as this ensures that the entire quarterly pool will be distributed among all qualifying groups. Before we open this up for questions, I would like to remind everybody there's a few reference links. First, there's lots of ACHN information at the Medicaid website, which is www.medicaid.alabama.gov. We also have a direct link to frequently asked questions. And finally, any questions that are not addressed today can be submitted for an official response by emailing them to achn@medicaid.alabama.gov. And before we answer some of the questions that are coming in through our chat box function, we'd like to first address some of our most commonly asked questions. The first question is, does the recipient have to be eligible for an entire year before they receive a risk score? The answer is no. Risk scores are calculated on a monthly basis, but the risk score is much more accurate with a full year's worth of data. However, we'd also remind you that recipients cannot be attributed to your practice unless they have at least 3 months of eligibility out of 24 in the ACHN program. Therefore, the risk scores of recipients attributed to your group will have at the very least 3 months of eligibility in claims data. The second question is the statewide per member per month for all of Alabama Medicaid eligible recipients? The answer is no. The statewide PMPM, again, is for the Medicaid recipients that are eligible for the ACHN program and are attributed to an ACHN participating PCP group. This next question is around the scoring cutoff. Why did you choose the median as the cutoff? As a reminder, the median is the middle score, effectively. Good question. We find that both costs and risk scores are highly skewed toward more expensive recipients. As a result, any subsequent average calculation of cost efficiency is going to be skewed as well. So the agency feels that choosing the median reduces the influence of some of these higher cost outliers and are more representative. Next, if I take care of critically ill patients, and therefore the cost of my patients is going to be higher, is there any way that I can be eligible for this bonus? The answer is yes. And this is why we are calculating your expected PMPM with our risk adjustments and our risk scoring methodology that we described earlier. In other words, if your patients are sicker, the average risk score for your attributed group will be higher. For example, if the average risk score of your attributed group is 2, that reflects that your patients are sicker because it estimates that your attributed group should be 2 times higher than the average attributed group from a cost standpoint. The risk score is applied to the statewide PMPM to calculate your expected PMPM and then compared to the actual. So yes, there's a way that you will be considered eligible for this bonus. And finally, is there additional detail on the data that goes into calculating risk scores? There is. Again, as mentioned, for the most part, risk scores are calculated based on claims data. We do incorporate recipients' demographic information. That's taken into consideration. Factors such as gender and age. And then the claims history, again, is for the previous year or the previous period is analyzed as well. And each item on that claim is taken into consideration, such as a place of service, a procedure code, or a diagnosis code as an example. So that covers our most commonly asked questions. We'll now start to take some of the forum questions.
Okay, the first question is, can you please go over how you will calculate the risk score for each practice?
Risk scores are calculated for each recipient that has been attributed to the group or practice. The risk score takes into account all claims, as was said previously. So then the risk score for each group is calculated by dividing the sum of the risk scores of all attributed members by the number of attributed members to that practice.
Okay. Will there be a dashboard that allows us to track our progress before we receive the report?
Yes, there will be. We anticipate beginning in January sending a quarterly scorecard that will allow each group to track their progress towards the threshold.
You said starting in January, it'll be a quarterly report.
It will be a quarterly dashboard.
Okay. Which recipient will not be included in the PMPM calculation? Which recipient will not be included in the PMPM calculation?
The answer is it depends. First, only attributed ACHN recipients will be included. So unless if the member has not had a visit in 2 years, as an example, they would not be included. If the recipient is attributed to a specialist group, they would not be attributed because this is used for bonus calculations. And also, as mentioned, there are certain cost categories that will not be included in the calculation, such as drug rebates and other costs that are not in the direct control or management capabilities of the respective PCP group.
Do OBGYN bump? If not, will patients be attributed to us and will we be responsible to do referrals? OBs do not qualify for the bump, but they can have patients attributed to them if they sign a PCP participation agreement and meet the participation requirements for primary care. I have a large number of ADHD and asthma patients in my practice compared to my local colleagues. How will this affect my bonus?
Again, your risk score will play a key factor in your bonus determination. So the actual experience of your recipients with chronic conditions will factor into your risk score. So if you do tend to have a sicker panel, or excuse me, not panel, a sicker list of attributed recipients, that will be factored into your expected PMPM, which factors into your cost effectiveness score. We are accounting for that, in short.
Do patients have to have a referral to see the gynecologist for services?
No, patients will not in this new ACHN program have to have a referral to see an OBGYN.
Will well checks or EPSDT screenings be factored into the bonus?
We will provide a definitive answer for sure, but if it's in the claim, then it would be factored.
That's all the questions we have. Sorry. One other just popped in. Previously, it was stated that an OBGYN does not have to have a referral to see a patient. Has that changed? Or does have to have a referral to see a patient? If it is for a primary care visit, if it's just for a well woman visit, that primary care to primary care referral is not needed. If it is for a maternity-related service, therefore, if the woman is pregnant, yes, a referral from the, you will have to have an ACHN referral number for a pregnancy visit to be seen. And the same would occur for nurse practitioners that are in an OBGYN office. If it is a primary well woman visit, there would not be a referral. But if it is a maternity-related visit, then yes, they would need a referral from the ACHN for reimbursement. What about problem visits other than an OB? Problem visits must have a referral.
That's a great question. Our webinar focused on the HCPs will be on Tuesday, and we will address this question at that time. So you'll have a complete vetted answer at that point.
That will end today's webinar.
Take it back. We have a couple of questions starting to come in now. How will vaccination rates affect the bonus? Vaccinations is quality bonus, and I would refer you to go back to the presentation we had on Tuesday. Tuesday was quality, Tuesday was quality measures, and I would refer back to that one. An ACHN referral number, please explain who gets this, PCP or specialist. An ACHN referral number would only be for a DHCP for a maternity-related service. The new maternity patients go to the health department to be seen by a care coordinator.
New maternity patients will go to the ACHN to receive care coordination through the ACHN.
How will we know who patients are attributed to? Will there be a list? Yes. At the beginning of every quarter, there will be a list that will be published, or the month prior to the start of a quarter, a list will be published, much the same that a patient first assignment panel is pushed out to the web portals for you to download. It will be Excel format as well as a PDF format. We encourage you to look at that. Any provider that has any patients attributed to them will be on that list, and it will list your current attributed patients, newly attributed patients, and patients who had previously been attributed to but have fallen off this quarter. There will also be on the web portal, you currently can check to see who the patient first provider is. You can see who the patient has been the patient is currently attributed to. There was a webinar on Tuesday. Is it available? Was the webinar Tuesday published yet?
Yes, all previous webinars for providers regarding the ACHN are available under the ACHN tab. If you'll select ACHN providers, and then you'll see a list of all presentations that we've done so far. They are posted. Even today's presentation should be available by close of business today, so you can go back and rewatch this webinar.
There's a question, where is the ACHN and how do maternity patients contact them? There is a list of the 7 ACHNs on the Medicaid website with their contact information, and if you are an OB/GYN or a DHCP, I would encourage you to reach out to them if you have not already to get that information. The ACHNs will have care coordinators staffed at their offices as well as some embedded with different provider offices. So I would reach out to the ACHNs for that are within your region. If I am a primary physician taking care of newborns in our nursery and I have a critical child that requires a transfer to the NICU, how will that affect my cost effectiveness?
As long as those claims are considered in that previous time period, that should affect the child's risk score, which would then also affect the group's risk score. So it should be taken into account that your actual PMPM has raised because of those NICU visits, but your risk score of your group should also take into account those NICU visits.
Why does it matter who a patient is attributed to for referral purposes? Patients can go anywhere for primary care, and that is correct. For primary to primary, there is no longer a need for a referral. Any other questions about cost effectiveness? What website do we find the ACHN care coordinator? Melanie, if you want to kind of talk about where they can find the map and the contact information for the ACHNs.
Thank you. Yes, all contact information for the ACHNs is available on that same site. If you go to the Medicaid website, just in case you don't have it, it's www.medicaid.alabama.gov. You'll see some tabs across the top. You click on the tab that says ACHN, and then you have options under that to click on ACHN providers. Once you're at the ACHN providers page, you'll see things like an overview. You'll see the ACHN regional map. If you click on that link for ACHN regional map, it shows you a map of the regions, and it's color-coded to go along with the contact information. Now, I will caution you, this contact information is just for providers, so do not pass this information out to your recipients. If you want information for contacts to the ACHN for recipients, you go to the Recipients tab.
As a sole nursery physician taking care of sicker newborns, how will this affect my cost effectiveness? It would be much the same as a sole nursery physician. Well, if you are a primary care provider, that would take into consideration the diagnosis of the patients that you're taking care of, and all the claims would be attributed, just like we discussed previously. If you are not a primary care provider, then it would not affect you as if you're a specialist, because the cost effectiveness bonus is only eligible for those participating PCP providers.
And also, the cost would only be calculated for attributed members, which again would entail 3 months of eligibility.
We also have quite a few questions that have come in about attribution, about quality measures, things like that. What we ask you to do is to review the previous slides and previous webinars, as well as our last webinar will be an open forum, And you as well may also submit any additional questions to achn@medicaid.alabama.gov, and we'll respond to all of those questions there as well.
Thank you again for today's participation in the webinar. Find this posted under the ACHN tab on the Medicaid website. Have a great day.